So the webinar will last for 1 hour, and during the session, you can post in the Q&A box or chat in the box. Us today, and we hope you will find information shared here very helpful. So today with me is, I wish to introduce our speaker today. She's Janet Wali, a senior nursing officer working at Kenyatta National Hospital in the newborn unit with a Bachelor of Science in Nursing. And even as she takes us through this presentation, I do welcome her because I know she really has a passion with these neonates. And on that case, our theme this week is closing the gap, breastfeeding support for all. So I hope you're going to really enjoy the session. One more thing to say here is that the event is CPD accredited, and with me is Franklin Babu, who will take care of the CPD points for all the nurses who will join us today. Otherwise, thank you very much. I believe you're going to enjoy the session. So I do welcome the next presenter, Janet Wali. Janet, karibu sana.
Good afternoon, everyone, from wherever you are listening or watching from. As you've heard, my name is Janet Wali. I'm a neonatal nurse working in KNHNBU. I am so glad to be the presenter for today's World Breastfeeding Week, which we've already discussed our theme. It's closing the gap, and we are saying that we are breastfeeding, or we are supporting all the breastfeeding mothers. Everyone who is breastfeeding, we are supporting them. So it's closing the gap and breastfeeding support for all. So we are all aware that World Breastfeeding Week is normally celebrated in August, which runs from 1st to 7th of August. And that is why we are seated here to commemorate the World Breastfeeding Week. So it was first started in 1992 by the World Alliance for Breastfeeding Action and is now observed in 120 countries. The week aims to raise awareness, like what we are doing now, sensitizing towards breastfeeding and advocating for better policies that support breastfeeding in private, public, and professional places. The WHO initially set a global target of 50% prevalence of exclusive breastfeeding by 2025, which was recently updated to 70% by 2030. So that means every member of the country, or all the countries that were mentioned in the WHO, are expected to achieve an exclusive breastfeeding prevalence of at least 70% by 2030. So as we move forward, we have our objectives. So we'll do the introduction. We'll talk about the breastfeeding technique. We'll discuss the breastfeeding positions. We'll also discuss breastfeeding benefits. We'll be looking at breastfeeding contraindications, we'll talk about challenges, and then finally, we will have our conclusion and takeaway as we continue. So I want to confirm from you that you are hearing us well, and you can see our slides before we continue. From the chat boxes, please confirm if you can hear me. Thank you very much. Let's continue. So breastfeeding is the feeding of an infant or young child with breast milk directly from the breast. God gave every human being a breast for the baby to breastfeed. God did not give us cow's milk. Therefore, we do not advocate for any other milk apart from the breast milk, which God himself created. It is the normal way of providing young infants with the nutrients they need for the healthy growth and development. Breast milk is very, very important because you notice that babies who are not breastfed are at risk. They have a risk of 14%, 4 times they are more likely to die before their first birthday. So non-breastfed babies are 14 times more likely to die before their first birthday. That's why it's important for us to be able to discuss breastfeeding. Later on, we'll see the contents of the breast milk that we are talking about and why it is important for us to feed our babies on the breast milk. So we look at the anatomy and physiology of the breast. As you can see on your right, this is the view of the breast, and you'll appreciate that this breast consists of glands, tissues that make milk, and the milk is propelled towards the nipple as the baby breastfeeds. It has 15 to 20 sections called lobes, and each lobe has smaller structures, which are called lobules. Now, the lobules are linked by thin tubes called the ducts, and these ducts are the ones that lead to the nipple in the center of the duct area of the skin called the areola. So as the baby breastfeeds, this milk comes out from the nipple. And as we shall be seeing from our subsequent slides, is that the baby's mouth or the baby has to put on the whole nipple in the mouth for good attachment so that they can breastfeed as appropriately enough. So we have types of breast milk. We all know that we start with the colostrum, which is secreted in the first week after delivery. This milk is very nutritious because it has more antibodies that the baby requires. It is secreted in small quantities and it is it has high protein levels which the baby requires. We all know that these babies, when they are born, their immunity is very low, so they need essential amino acids for them to be protected from infections. So our colostrum is safe for our babies. We then therefore go to transition milk, which is secreted during the 2 weeks after birth of the baby. And then it contains immunoglobulin, and notice that it is low in protein as compared to the colostrum. It has increase in fat and sugar content. So this is a picture on your right illustrating how the transition milk looks like. We also have the preterm milk, which is high in quantity and it has a lot of proteins, as we can see. It contains a lot of sodium, iron, and immunoglobulins, as we have discussed, because even the preterm babies require more immunoglobulins because of their reduced level of immunity. We also have types of milk. We have the mature milk. The mature milk follows the transition milk that we have just talked about. It is more thinner and watery. It contains all essential nutrients for the growth of the baby. So as we continue talking about the breast milk, we have two types. We have the fore milk and the hind milk. As the baby breastfeeds, we always make sure that they get both the fore milk and the hind milk. And when we start with the fore milk, we realize that it's secreted at the start of the feed. It is watery, rich in proteins. It has sugar, vitamins, minerals, and water. And this is why we tell our mothers to breastfeed the baby exclusively for 6 months without giving water or anything, because the breast milk, the fore milk, satisfies the baby's thirst. So because it contains a lot of water in it. Then we have the hind milk, which comes later as the baby breastfeeds. It's richer in fats. And for those that work in newborn, you need to realize that we tell the mothers who give birth to preterm babies to express the first fore milk and give more hind milk, because we want the babies to add weight, especially those that are not doing well with weight gain. So it is richer in fat content. It provides more energy and satisfies the baby's hunger. It's very important for the optimal growth. It is very important for you to note that as you encourage the mothers to breastfeed, let them do both the fore and hind milk. So how you do this is by encouraging them to empty one breast breastfeed the baby the first breast until they completely empty it before they move to the next one, so that the baby gets both the foremilk and the hind milk for them to get the right nutrients, as we have discussed earlier on. Let's talk about the storage of breast milk. We notice that there are mothers who return to work early before the 6 months, and there are those babies that are born either with less or not developed sucking reflex, and some of them are even having maybe congenital anomalies like the cleft lip and palate. So you encourage the mothers to express the breast milk. Therefore, we need to teach the mothers on how to express the milk the way it's supposed to be, and then therefore teach them as well on how to store this breast milk. Because if we do not store it well, then sometimes we give milk that is not good enough. So human milk can be stored at room temperature for 6 to 8 hours. If you are storing in an insulated cooler bag with ice packs, you can store it up to 24 hours. It can also be stored in the refrigerator for 5 days at about 40 degrees Fahrenheit. Or if you're using a degree centigrade, it's 4 degrees centigrade. It can be kept in the freezer compartment up to 2 weeks at 0 to 5 degrees Fahrenheit. For a deep freezer, it goes up to 3 to 12 months. And an important thing here to note is that once they are ready to use this milk that has been stored, you do not tell them to warm it on the microwave. They put it under a warm water. They do not put it on sufurias to heat or microwaves like the way people want things like now. So you just place it for some time under warm water to heat before you feed the baby. Let's talk about the breastfeeding tips. On our left, you see a baby that is being breastfed. You notice this is a baby who is latching well because he's comfortable, he's seated comfortably and breastfeeding. There are no signs of pain. The areola is visible above the baby's mouth and below. You can actually not see any areola from this picture because the baby's mouth is wide open. Their lower lip is turned out. Their chin is touching or nearly touching the breast. So these are the good signs or the signs that you can tell your baby is latching well as you breastfeed. As we look at this technique, they are more related with the tips that we have talked about. So you can notice that the mouth is wide open, the lower lip is turned outward. The chin is also touching the breast, and like we have talked in the previous slide, you can see that more areola is visible above the baby's mouth and below it. So those are the things that we talk about for us to know our baby is latching well and we are using the correct technique to breastfeed. Let's look at this picture on our left, on our right. This baby has good positioning. As the mother is breastfeeding, the baby's head and body are in line. Baby's head close to the body, baby's whole body supported with your arm along their back. So notice the mother is supporting the baby's head and supporting the back as well. This is particularly important for newborns and young babies. But for older babies, support of the upper part of the body is usually enough, unlike the smaller babies. So for us to see, or for us to say our baby is sucking effectively, what do we look at? These are the things that we are looking at. The baby takes slow, deep suckles. Sometimes the baby, you notice the baby might be pausing. You may be able to see or hear your baby swallowing after 1 to 2 suckles. And this baby is normally very comfortable and pain-free. Baby is finishing the feeds, releases the breast on their own, and they look contented and relaxed. Actually, the baby is very happy after they breastfeed and they show signs of effective sucking. The breast is softer after every feed. So that is how you tell your baby is effectively sucking. We have several benefits breastfeeding, but we cannot talk about breastfeeding without talking about skin-to-skin contact. We all know that even as our mothers deliver in our labor wards, we encourage skin-to-skin immediately after birth. And there are several benefits that comes with this. And the reason why we encourage skin-to-skin is for us to be able even to initiate breastfeeding early enough within 30 minutes to 1 hour. So the skin-to-skin contact has several benefits. Like I have said, it comes and relaxes both the mother and the baby. Skin-to-skin regulates the baby's temperature. We are struggling very much with hypothermia in newborn units, and skin-to-skin is the solution for all this. Once the baby is born, please place the baby on the mother's skin so that they can regulate the baby's temperature, their heart rate, and their breathing. It stimulates digestion and an interest in feeding. Actually, as you place that baby on skin to skin, they will initiate breastfeeding on their own when you leave them with their mother. It also helps protect against infection. And like how we are used to transferring this baby, separating the baby with the mother and taking the baby to the radiant warmer. Once you leave this baby on the mother's skin-to-skin contact, you're actually protecting against infections, and this is what we are advocating for. So let us look at the breastfeeding positions. We have several of them, as we can see from our picture, and we will talk about them one by one and see how we can do this together. I hope we are still following. So let us start with the number 1 position. We call it cradle hold. From our picture, you notice this is the cradle hold that we are talking about, and it's the most used position. It helps provide an enjoyable feeding and bonding experience for both the mother and the baby. So what normally happens, we encourage the mother to sit upright somewhere with support to keep the arm and at the right height, like an armed chair or couch. If needed, they can support, or they can use pillows to support the arm. So this position, it's like I've said, it's the one that is mostly used. So you also position your little one in your lap with the head in the crook of your arm. So the head of the baby lies on the crook of the mother's arm, and the baby's chest is against the mother's, so that they do not have to turn the head towards the breast. If necessary, you can use pillows to make the mothers comfortable and support the baby's head. Let's look at our second breastfeeding position. We call it cross cradle hold. It's this position is useful when first learning. The first time mothers can use this because they normally struggle a lot to breastfeed their babies. So this is the best position for them because it allows you to control the baby's head while helping her to latch. You think of it as the reverse of the cradle hold. It's just like the opposite of what we have just discussed about. And to perform the cross cradle hold, you position your baby in the opposite direction of the cradle hold with your head in your hand rather than the crook of your arm, unlike what we saw in the previous picture. So while turned on your side, that is the baby, hold your baby. Okay, so to perform the cross cradle hold, position your baby in the opposite direction of the cradle hold with your head in your hand rather than the crook of your arm. So that is what we have just discussed. That is the cross cradle position. Let us move next to the position that we call football. It's commonly called football hold. You can also call it underarm hold or rugby hold. This is a position to breastfeed the baby, especially those that the mothers that have been done cesarean section, because it does not press on the incision, scar, and it's also very useful for mothers with engorged breast and sore nipples, because it prevents plugged ducts by positioning your baby to empty the bottom duct. So for those that have sore nipples or engorged breast, you encourage them to use this football hold. At the same time, CS mothers can also use this position comfortably. So how does it go? You position the baby under, position your baby's legs under the arm. Use the other hand to support the breast. Like I have already mentioned, it is best for CS mothers and those that are having engorged breast and sore nipples. The next position is sideline position. This sideline position, as you can see from the picture, the mother lies next to her baby. It is very important to note that the baby and the mother, both the baby and the mother are very comfortable in this great position. So the mother lies as they support their head with the pillow and ensure that the baby's nose isn't obstructed. One thing that you can see from this picture, especially the first-time mothers, if they choose to use the sideline position, emphasize to them that they need to take care of the baby's nose because it can easily be obstructed. Our next position is reclining position. The mother is reclining and appears very comfortable, as well as the baby. This position is very key to those who have difficulty latching and those babies that are restless, crying. It's the best position for them because you can see both the mother and the baby are like having skin to skin contact. So it helps the baby to calm down as they breastfeed. It's actually called a biological nurturing position. The reclining position is called biological nurturing position because biologically this is how the baby is supposed to breastfeed. Let's move to benefits of breastfeeding, and we have several benefits that I know if I was to ask a question, I'm sure all of us will not miss something to say. So as we start with the babies, let's look at benefits of breastfeeding to babies. From the constituents or from what the milk contains, we can see that it provides key ingredients for healthy development. We have seen that they have the amino acids that the baby requires. They also contains optimum nutrients for the baby to grow. They supply pre and probiotics for digestion. You notice that a baby who is being fed on formula cannot be compared to a baby who is breastfeeding. The digestion is very smooth and they have less colic pains as compared to those that are not breastfed. So they supply pre and probiotics. They just a minute, we're having a technical hitch. Sorry for that technical hitch. We were talking about benefits of breastfeeding. I hope you can hear us well. So we've already talked about the first 2 points, the first 3 points actually. We have said about breast milk protecting against diseases like asthma, sudden infant death syndrome, and we have also talked about it prevents obesity, in that our babies cannot be overweight because it has the right quantities of essential nutrients that our baby needs. It is also a good brain booster. Our babies that are breastfed are actually very intelligent. Their IQ is very high, and therefore we advocate for breastfeeding exclusively for the first 6 months. Now we talk about benefits of breastfeeding for the mothers. We notice that mothers also benefit a lot when they breastfeed. And pregnancy comes with weight gain. So as they breastfeed, the mothers lose a lot of weight. It also improves on postpartum recovery. It may reduce the risk of ovarian and breast cancer as the mother breastfeeds. And finally, it helps beat the postpartum blues. These mothers are more relaxed because as they breastfeed, the feel-good hormones are released, and the mothers are relaxed and they are happy with the babies. Therefore, the postpartum blue does not appear as much. So for both the mother and the baby, breastfeeding helps them to bond, and they are happy. We have a happy mother and a happy baby because of the bonding that comes with breastfeeding. We also have contraindication to breastfeeding. So we have 5 of them. Number 1 is classic galactosemia in the infant, which is an absolute contraindication to breastfeeding. You notice that galactosemia is an autosomal recessive deficient of an enzyme called GALT. In full, it's galactose 1-phosphate uridyl transferase, which is actually deficient in a baby. So when you feed this baby on breast milk, they're not able to metabolize the galactose or the sugar, which is galactose to be specific. So this is a contraindication to breastfeeding. Number 2, untreated HIV, stroke, AIDS infections, especially with very high viral loads, we can say that it's contraindicated to breastfeeding. Number 3 is chemotherapy or radiation. Mothers who are having any form of cancer, who are undergoing chemotherapy or radiation, are contraindicated to breastfeed. Number 4 is active tuberculosis. You can realize that when a mother has TB, they can easily transmit because this is transmitted through airborne. So the babies can easily get tuberculosis, therefore it's contraindicated. And then finally, we see that substances like opioids, cocaine, and phencyclidine are contraindicated to breastfeeding mothers because they can easily be passed to the babies and cause long-term neurodevelopmental effects in the babies. So those are the contraindications of breastfeeding. The challenges that come with breastfeeding, we have the sore nipples, we have breast engorgement, we have low milk supply, and sometimes the challenges that can come with breastfeeding is someone maybe who is going to work earlier enough before even the 3 months, which we'll discuss about this. So those are some of the challenges that can come with breastfeeding. So let's talk about breastfeeding support at workplace. How do we encourage our colleagues who are breastfeeding, or how do we support breastfeeding colleagues or breastfeeding employees at your workplace? We have talked about the benefits of breast milk, and we have seen that breast milk is the most effective source of nutrition for toddlers and should never be replaced. If God wanted us to have cow's milk in our breast, he would have put cow's milk in our breast, but he gave us breast milk, which is the best food for our babies, so it should never be replaced. Most workplaces do not have the infrastructure or policies to aid young mothers with breastfeeding or expressing milk. This ultimately makes work difficult for breastfeeding women. And we have ways in which companies can support breastfeeding employees. Let's look at them one by one. So number one is having a breastfeeding room in the workplace. I wonder whether you have a breastfeeding room in your place of work. You can put in our chat boxes if we have breastfeeding rooms in the place of work. We also need to incorporate time to allow the mothers to express the breast milk. Remember, the babies are normally left at home, so they need to express the breast milk and carry it at home. So we need to have enough time for them to express this milk and carry for their babies. We need to allow for transition options such as part-time work, telecommuting, flexible schedules, or job sharing so that the mothers can have adequate time with their babies to bond and to breastfeed. We also need to allow access to baby at work through on-site childcare. Like some facilities, what they have done, they have actually built a very good facility to allow the mother, the mother comes with the house manager, and when the mother gets time, she rushes, breastfeeds, and come back to work. So we need to advocate for this so that our babies can breastfeed up to 6 months and we will have a healthy nation. So conclusions and takeaway, we see that when you forget everything that I've said today, please remember that breastfeeding is a rewarding journey that offers numerous benefits for both the mother and the baby. With knowledge, support, and a little patience. We need patience even as we breastfeed. Breastfeeding can be a beautiful and fulfilling experience. Cherish this special time, nourishing and bonding with your baby. And remember, getting the hang of breastfeeding takes time. So we need patience. Be patient with yourself and always reach out to your healthcare provider for support if needed. So the current trends in Kenya about breastfeeding mothers, we talk about the Breastfeeding Act 2024. The bill aims at establishing a supportive legal framework for breastfeeding mothers in the workplace and has passed its first reading. Actually, it's something that has been discussed in Parliament and is now open for public input through memoranda submissions. Once it's enacted, it will help uphold a mother's right to breastfeed freely or express milk for their infants. So we see we are heading somewhere. It's actually in Parliament, and we'll have our babies very healthy through breastfeeding exclusively. One of the primary implications of Breastfeeding Mothers Act 2024 is the requirement for employers to provide adequate support for breastfeeding mothers. And this includes the 5 things that are outlined on that slide. Number 1, having a designated lactation place, like we have discussed previously. We all need to have a lactation place for our mothers to breastfeed and to express breast milk. Number 2, we need to have baby changing facilities. They talk about any facility that holds more than 50 people need to have a changing facility for the baby, like in malls, in churches, every workplace, because we hold more than 50 people. We need to have a changing facility for our baby. So we need to advocate for this as we wait for the bill to be enacted. We also have development programs, and when we talk about development programs, we are saying that every workplace needs to have a place that the mother can go and breastfeed the baby. So these programs or these facilities that we're talking about need to be safe for the baby. They need to allow the baby to grow. It should be a conducive place, environment that is safe for the baby to develop both cognitive, emotional, social, and be able to develop language abilities. The facilities should be very safe for the mother and the baby. We also need to have public breastfeeding areas in our place, and we also need to have flexible working hours so that the mother can bond with the baby and be able to do exclusive breastfeeding for 6 months and continue after complementary feeds up to 2 years or even more. So this is what we need to advocate for in our country and where we are working. We will appreciate that breastfed infants are healthy infants. We will actually have reduced morbidity and mortality for our babies if they are breastfed. We have seen the benefits, and I cannot re-emphasize more on this. Breastfed infants are healthy infants. So these are our references. This is where we got the material that we have presented today. So I want to hand over to my colleague, Joanne, to take up the questions. And then we will answer together. Thank you very much and enjoy the remaining session.
Thank you very much, Janet. You've done a good job. Congrats. And you can actually see they're really appreciating the presentation. So we now move to the question and answer, and I'll start with James. So the first question is, if a woman becomes pregnant before the baby is 1, I guess he meant 1 year, should she stop breastfeeding? And if not, for how long? So for that specific answer, maybe I'll take it up. It all depends on the mother and her decision. We have some who will prefer to stop. Of course, we all understand that whenever a mother is pregnant, they do develop some tenderness of the nipple. So probably they might be feeling uncomfortable. So we have these mothers who will stop breastfeeding. And of course, the other thing to note is that we may have the milk supply may diminish. This might lead the baby to refusal to breastfeed. So basically, it all depends with the mother. And at some point, you'll realize we have mothers who will continue with breastfeeding, and they even deliver, and you find them breastfeed the older child and the newborn baby. Thank you very much, James. So we move to the next question. There is, what is the recommended temperature ranges for storing breast milk in the deep freezer? I think she had mentioned, maybe Janet, you can take us through that.
Thank you for that question. Thank you for that question. I had mentioned about the storage of breast milk. Let me start from what I said. We store our breast milk on room temperature up to 8 hours from the slide that we have presented. On our cooler with frozen ice packs, we store up to 24 hours. On our refrigerator at 4 degrees centigrade or 40 degrees Fahrenheit, we store up to 1 week. The freezer should be at 18 degrees or below, and that is 6 months. Then for the deep freezer, the temperature is negative 20 degrees, and we can store up to 12 months. So that is talking about the storage of breast milk. I hope we have answered your question. Thank you.
Thank you, Janet. We move to the next one. It is important to stress on storage of milk. So old milk, this I think is a comment, old milk should be used first. That one I agree with you. And milk that has already been thawed should never be refrozen. Very, very true. It can be used to wash the baby or discarded. I don't know about the washing the baby. That's an anonymous attendee. So thank you very much for that comment and for the addition.
So it's first in, first out?
Yes. So the other question is, how should a mother with twins breastfeed her baby for healthy weight gain? Go back to the positions. To you, Janet.
So how should a mother who has twins breastfeed her baby? You remember the football hold position? Yes, you can actually, a mother who has delivered twins, this is a perfect position for them to breastfeed. One baby can feed on the right and the other one can feed on the left. So this is a perfect position for a baby who has twins. And sometimes you even encourage the mother to express so that they can top up after breastfeeding, because now we are dealing with twins. We need to make sure that these babies are satisfied. So I think to add on that, you can encourage breastfeeding and then top up just to make sure the babies are satisfied, because they are two and not one. So football hold is a very good position for breastfeeding twins. Thank you.
Thank you, Janet, for that. Then the other one is, how can skin-to-skin breastfeeding help stop infections?
Thank you, Charles Koech. So from, I think, the very first slide that I talked about on skin, benefits of skin to skin, I mentioned a setting in labor ward where a mother has delivered. And from what we have seen in the old practice, baby is born and the cord is cut. Of course, we do delayed cord cutting, but you notice that these babies are separated from the mother, in that the healthcare worker takes the baby away from the mother to either weigh the baby immediately or give vitamin K and TO away from the mother on the radiant warmer. That is a practice that has been happening. So I mentioned one benefit of skin-to-skin contact is where we are advocating for, once the baby is born, leave the baby on the mother's abdomen. As you do your delayed cord cutting, do it on the mother's abdomen. Dry and stimulate the baby, change the wet towel, and leave that baby on the mother's abdomen, so that all the essential newborn care is done on the mother's abdomen. We're actually talking about the warm chain by delaying weighing. So leave the baby on the mother's abdomen, do your all essential newborn care while the baby is on the mother's abdomen, and delay the weighing, delay the birthing of the baby. Just leave that baby on skin to skin for them to establish breastfeeding as soon as possible. And when you do that, they will naturally move to the breast to initiate breastfeeding themselves within 30 minutes to 1 hour. So that is how skin to skin prevents or reduces infections, because a baby who is transferred to the radiant warmer, that radiant warmer could have been shared by someone else. So they will most likely get infections by being taken to the radiant warmer instead of them being left on the mother's abdomen, skin to skin. So that is how it reduces infection. I hope it is clear, Charles. Thank you.
Thank you, Janet. To the next question. Why is it we have normalized, this is an anonymous, why is it we have normalized giving formula milk, especially to babies born of CS mothers or primary gravidas? Why can't we advocate for frequent latching and breastfeeding, as we know this is how milk is let down? So I agree with you on this, and basically even UNICEF recommends that we really need to be baby-friendly hospital initiative. So basically we really need to ensure that we promote breastfeeding practices, we protect these babies and even support breastfeeding. So I think this is a challenge to most of our facilities, to really encourage mothers to promote rubbing in and allowing mothers to start breastfeeding the babies immediately after delivery. Thank you very much. So we move to the next question. Thanks for quite informative topic. Please talk more about the pre and probiotics, a new product in the market.
Okay. We talked about pre and probiotics as what is contained in the breast milk. And that is why I started by saying the breast milk is the best for the baby, because it contains about pre and probiotics. So we have said that one of the benefits of these probiotics, as I mentioned, it's that it supports the baby to have a healthy digestion even as they breastfeed. So that milk that we give, that breast milk that we encourage the mothers to breastfeed is perfect because it contains these probiotics, because they're very important for digestion. They also promote our it also promotes healthy immune response. You notice that our baby's gut, or the baby in general, have low immunity. So these probiotics help our babies fight against the infections. Number 3, it also reduces NEC. What we call NEC is necrotizing enterocolitis, which is a late onset of sepsis. So prebiotics or the probiotics are very key on those 3 areas: digestion, they promote healthy immune response, and they reduce the NEC, which are all contained in our breast milk. That is why we should not supplement, we should not use anything else apart from breast milk. In a circumstance where you're not able to get the breast milk, our second choice is the donor milk, which I think most facilities have started having that facility that can provide mothers to have, can make sure that the mothers have the donor milk. And then our number 3 choice is formula. Then number 4 choice is IV fluids for those babies that are sick. But our number 1 best food for our babies is breast milk. If not, then we do donor milk. Thank you. I hope we have answered you. I hope we have answered your concerns.
Thank you for that. So the other question from James is how is early diagnosis of galactosemia done? So for this, basically you just take a blood sample from baby's heel. This sample is put on a special piece of paper, and then basically it's sent for screening and for analysis. Thank you very much, James. So the next question goes to Janet, and this one is, I can't see the name, but the question is, what's the best cow milk or formula for HIV exposed children who aren't breastfed exclusively for 6 months due to various challenges? Over to you, Janet.
Thank you for that question. It's saying, what's the best cow's milk or formula for HIV exposed children who aren't breastfed exclusively for 6 months due to various challenges? We all know that we advocate for breastfeeding. Whether the baby is HIV exposed or not, breast milk still remains to be number 1, unless in a circumstance where the mother maybe has very high viral load, then we can always opt for donor milk. That is why I started by saying we go for breast milk. Number 2 is donor milk. In rare circumstances, would we advocate for formulas? Because of what we have seen, the benefits of the breast milk are very, very key to our baby. So notice that the current updates, or what we are talking about now on our HIV exposed babies, is that they all breastfeed exclusively for 6 months. Like just any other baby, they need to breastfeed for 6 months. And then they start the complementary feeds after 6 months. They can continue breastfeeding up to 1 year or even up to 2 years, depending on the mother's condition. Now, this mother needs to be monitored closely. They need to go to a clinic where they're given antiretrovirals so that the viral loads are kept lower, so that the chances of transmitting to the baby through the breast milk are minimal. So we are advocating for the breast milk. In a circumstance where there's no breast milk, please let's go for donor milk. But I cannot recommend any formula at the moment. That is why we are talking about breastfeeding. Thank you very much.
Thank you, Janet. So the other question again is it not advisable? I think this is a comment. Is it not advisable to start teaching about breastfeeding in the antenatal clinics to avoid bombarding mothers, especially new ones, all at once? I agree with you. Truly speaking, we really need to keep teaching our moms in the antenatal clinic. We give them the information because at that point, that is the time they are really keen to learn more on how to care for their babies. And I believe at that point, it's easy for them to learn than us waiting for them to deliver and then we give the teaching. So I agree with you. Truly speaking, we need to keep teaching these mothers before the delivery. Thank you for that. Then the other question comes from Paul Olik, and it's a comment. Sorry. Yeah. Oh, this is just a comment. Thank you very much, Paul, for your comment. It's a nice presentation. We really appreciate. Then another question is, hello, I would like to inquire where one can get the recorded videos. That one, I think we will give you the feedback before we finish the presentation. From Lydia Mayaka, thank you for your question. What can we do to seropositive mothers who are unable to lactate in the early days post-delivery? What should we feed these babies while we wait for the mother to start producing milk? To you, Janet.
I would say that is an interesting question. As we await the mother to produce milk, I think it raises a lot of debates because, again, we are thinking of mixed feeding. So I don't know what you would say. I know this is a tough one, but depending on the baby's condition, I would say we do not want to do mixed feeding. You do not want to start formula as you wait for the mother to get milk. So one thing I would comment on this is that, you know, the skin to skin that we have talked about, you can actually maximize it. Put this baby on skin to skin. And it has been shown, research has shown that it actually promotes that breast milk to start flowing. So I think we can do everything we can, try skin to skin, so that the breast can flow. In extreme circumstances, I think we can even start the baby on IV fluids if the mother has no milk at all, or my number 2 option, having a donor milk as we await the mother to have enough milk. Actually, we should go for donor milk. We should actually advocate to have milk banks in our facilities because these are challenges that we come across. So as we await for the mother to have this milk, and we have explored all options of having skin to skin and giving the mother the warm drinks that they require, encouraging them, giving that psychological support, we can do donor milk. In extreme circumstances, when the baby is very sick, we can actually start on IV fluids as we await lactation to establish. Thank you, Lydia.
Thank you for that. The other question is from Bernard. He asked, are there chances to increase maternity days? Thank you very much, Bernard. I know from my end, I will not be in a position to answer that, but I believe probably if you're having policymakers with us, they are likely to help us out on that so that they can push it to at least 6 months, which can really do us good. I don't know if the paternity leave too also needs to be added. Yeah? That's for us to think about. So the other question is, young mothers should smile. It's a comment, I think. Young mothers should smile for their future is bright. But for the older nurses, it was not easy for us, but God saw us through. Thank you for your comments. Let me check through. So thank you. There's another question here. There's a comment from John Masasabi. Great and very clear and informative presentation. We really appreciate, John. Thank you very much. There's a question here. Is there more benefit of breastfeeding up to 2 years, or the best is exclusive for the first 6 months only? Janet, to you kindly.
The benefits go all the way up to 2 years, but notice that the breast milk contents reduces as the baby breastfeeds, and that is why we complement feeds at 6 months. So most nutrients are normally reduced as the baby continues to breastfeed. However, the bonding extends even more than 2 years. You realize that this mother and the baby that breastfeeds even for 2 years or more, you cannot compare with someone who stopped breastfeeding at 6 months. The bonding extends. So we can say the benefits go all the way.
Thank you. Again, this comes to you, Janet. To those HIV, this is a question from Eugene Mumelo. To those HIV exposed mothers are supposed to breastfeed exclusively. What happens in a scenario where an exposed mother has given birth to multiple babies and the breast milk isn't enough?
So this is a scenario where we have an HIV positive mother with twins or triplets, and the breast milk is not enough. So I can say that we can opt to, again, we are not working in isolation. We need to consult. We have neonatologists, we have doctors around us or people around us that we can collaborate with, work as a team. Even as we approach and decide on what to do, we need to involve everyone. The nutritionist, the social worker needs to come in handy as we discuss different scenarios for the mothers that we come across. Again, I would say in this scenario, depending on the scenario, maybe you can, yes, we advocate for breastfeeding, but if the milk is not enough, I think we can breastfeed exclusively for certain months and then stop and then continue with the formula milk. That is what I would say. But again, you need to work as a team. You don't make a conclusion alone. Please involve other people and make a conclusive decision for the betterment of both the mother and the children. Thank you.
Thank you, Janet. This, I think, is a comment from one of the participants. Thank you for the presentation. Very easy to understand and has my objectives met. Much appreciation. Thank you very much for the comment. Then the other question here is, please elaborate on the myth regarding the effects of breastfeeding on breast anatomy, as young mothers would opt not to breastfeed to continue looking young and bubbly.
That's an interesting one. Please, let me read the question again so that everyone can hear. Please elaborate on the myth regarding to effects of breastfeeding on breast anatomy, as young mothers would opt not to breastfeed to continue looking young and bubbly. I actually remembered one of my lecturers talking about this a few years back, and she told us whether you choose to breastfeed or not, when age catches up, the anatomy will not remain the same. So whether you breastfeed or not, nature just takes its course. So the best thing is just to breastfeed. Even if nature takes its course in the near future as you age, at least your baby will have benefited, and you will have benefited as well, because you'll be having a perfect bond with your baby. So I want to say that whether you breastfeed or not, the anatomy will still be affected. So choose to breastfeed your baby. Thanks.
Thank you for that, Janet. The other question from Priscilla, I think, has been answered. about the current practice for HIV positive mothers. I think we have talked about that. Then we have another question from Kiru James. How do you manage an engorged, painful breast with short nipples? So for this one, basically you need to gently massage we need to support these mothers to gently massage their breast to help with milk flow during breastfeeding or pumping. And then if probably we can get frozen wet towels, this could help, or ice packs we place around the breast for around 15 minutes. And one other thing we need to emphasize to the mothers is that they need to avoid putting on tight bras that will press on the breast. Then, because tight bra can cause blocked milk ducts. Then probably at the same time, I can just talk briefly about prevention of breast engorgement. They need to put warm wet face cloths on the breast before breastfeeding. This one will help in let down, and it will increase the flow of milk. Otherwise, thank you very much for that question. We proceed with the Q&A. So the other question here is so a mother who falls pregnant and has an infant can still breastfeed until the pregnancy is 7 months. This is a comment. Then stops to allow for build of colostrum for the newborn. Thank you for that comment. Yeah. Then there's this other one. Is a mother with twins allowed to allocate each twin his or her breast without sharing? I don't. This is from Geoffrey Opio. Thank you very much, Geoffrey, for your question. Personally, I may not agree with this. I think we need to keep changing the breast. So we need not to allocate one breast for one twin and the other breast for the other twin. I think that is not allowed. Yeah. So it's good for them to keep interchanging. Yeah. Thank you very much, Godfrey. Then there's a question here from Elvis Osumba. In situation where an HIV/AIDS mother newly diagnosed after 6 weeks of breastfeeding, how will you help the infant as breastfeeding is contraindicated to HIV/AIDS mother? I think you had mentioned something to do with that. Janet had mentioned, maybe she can emphasize.
In situation where HIV/AIDS mother is newly diagnosed after 6 weeks of breastfeeding, how will you help the infant as breastfeeding is contraindicated? It is not cast on stone. I mentioned it as a contraindication when we have very high viral loads. But this mother at 6 weeks who is newly diagnosed does not mean that the viral load will be high. So depending on how the situation is, we can actually collaborate with our team and decide what is best for a baby, but it's not cast on stone that when you have HIV or AIDS, it is contraindicated. It depends with your viral load. Thank you. Someone says, thank you for this presentation. Kindly explain for us the procedure of ceasing breastfeeding. I want to confirm that you mean stopping breastfeeding. Kindly explain for us the procedures of ceasing breastfeeding. Joan, you want to answer that? So how do we stop breastfeeding our babies? This one, I want to welcome people, everyone in our chat boxes. Maybe you can give a comment on how you think we can actually stop breastfeeding. Anyone, please? I'm sure your mics are muted, so you are not able to talk. So please kindly communicate to us on the chat boxes on ways on how we can stop the babies from breastfeeding. Comments, please, as we continue.
Thank you. As we wait for the comments from your end, we'll continue with the questions. And so the next question is from Linda. Linda, what will happen to the baby after mother develops breast abscess and nipple cracking? Should the baby be initiated on formula feeds?
So when we have a baby with sore nipples, or like the way you put it, nipple cracking, what we normally do, we encourage them to breastfeed and apply the breast milk on the cracked nipple. It actually helps in promoting healing. So we do not encourage the mother to stop to breastfeed, because once we stop to breastfeed, the breast becomes very much engorged and the conditions will worsen. So we encourage them to apply the EBM or the express breast milk on that sore or cracked nipple for it to heal. We don't stop breastfeeding from there.
Okay, thank you for that, Janet. And so there's this question that Kennedy asked about the procedure for ceasing breastfeeding. So basically, what I can say here is that it all depends with the mother and comforts. So she really needs to have, of course, probably from 2 years around there about the mother, the way we do weaning. So I think it's something that a mother can do to start weaning off slowly by slowly. So she can start by weaning off a feed, probably skip feed that is breastfeeding, maybe one meal that is a breastfeeding meal. And then from there, she'll keep weaning off as she increases on the normal feeds. Thank you. The other question is, it's a comment here. Thanks for the educative, this is from Eugene. Thanks for the educative presentation. In scenarios where breast milk isn't enough, can we advocate for milk let-down drug stimulators?
I would say, thank you, Eugene. I would say there's nothing wrong with that, because what we want to achieve is the breast milk. So if the mother doesn't have enough milk, we can actually, that's why I said we need to involve even the nutritionist. There are products that they give to the mothers to help with the let-down reflex. And if these products do not produce or do not give us a positive outcome, we go ahead and use the drug. So yes, we can use drugs for milk let-down. Thank you.
The other comment is it's a comment from Lovino Joan. Nice presentation, so educative. Thank you very much, Lovin, for your comments. Then, hello, what do you mean by donor milk? What form of screening is done to ensure safety? Janet, over to you.
So we normally have a donor milk. In Kenyatta, we are yet to have one, but I know there's one in Pumwani Maternity Hospital, where the mothers, before they donate their milk, they are normally screened for hepatitis and HIV. This milk goes through a series of screening before it is made safe for a baby to be donated for. So when the milk has been screened and has gone through those many processes, it is actually safe. By the time it's given to a baby, by the time it's referred to as donor milk, it is actually safe and clean for the baby, just like blood transfusion. It is normally screened very well before it's given to someone. So the same way, the donor milk has to be screened, and it goes through several stages before it is declared safe for the baby. Thank you very much. That is a very good question. So we are moving on with our question and answer session. Our next question is from Lillian Omondi. Thank you for the presentation. She says, what is the best position for breastfeeding for mother following cesarean section? I think we have talked about this from the different positions that we saw. Let me go back to the screen. Remember, we talked about the cradle hold, the cross cradle, the football hold, and this is actually, we talked about cross cradle and the football hold. We say this football hold is the appropriate position for a mother who is breastfeeding, because you see that the baby's body is away from the cesarean scar. So this is the best position for babies, for mothers who have been done cesarean section. Thank you very much.
Thank you, Lillian. Thank you, Janet. The next question, I think we had handled that. So the other question is from Marion Kamau. Do you recommend use of drugs to enhance milk production to mothers experiencing low milk production? If yes, which ones? For this case, from our end and what we've been practicing here, we've in support from the nutritionist, they've been giving mothers the Mammalay supplements, and it has really worked good for us. And I believe we still have more other supplements that mothers can be given to enhance milk production. From Ruth Nyansikera, thank you. Please share the CPD code. Thank you, Ruth. We will share that shortly in a few. Then, do a mother continue to breastfeed in the case of having breast engorgement?
Sorry. Do a mother continue to breastfeed in case of having, we've already talked about this. I think we have tackled, we have said that do not stop breastfeeding completely. So we continue breastfeeding. Actually, the breast engorgement means that this mother is having a lot of milk inside that breast. So we can actually encourage her to express, use warm compresses, and encourage her to breastfeed the baby so that the breast can be fully be emptied by the baby breastfeeding.
Thank you for that. The other question is from Phoebe Otieno. What causes complete lack of milk? How do you help the mother? For this case, Janet mentioned that naturally God has created us in a way that once you deliver, there has to be milk let down. And for this, I'll basically say it all depends on the mother's condition. We have these mothers, probably they are on treatment, which suppresses the milk let down. We have mothers probably who have undergone stress. We all understand that even pain after CS, that is a form of stress to this mother. So basically, I think as healthcare providers, we really need to be there for these mothers, support them, talk to them, and of course, feed them, ensure that they eat well, they take plenty of fluids, and I believe they really have to get some milk. Thank you for that, Phoebe. The other question is from Lillian Omondi. Enlighten us on effective breastfeeding for twins. You want to add? We've already tackled that, Lillian. Thank you for the question. Ruth Mugo, very well done. Congratulations. Thank you, Ruth. We really appreciate. Then, is it advisable to continue breastfeeding with a pregnancy? Yes, we said depends. We really tackled that. Thank you for that question. What advice would you give mothers with flat nipples?
We can actually, thank you for that question. We can actually start physical examination right from our antenatal clinics and notice this mother who has a flat nipple. So in the market nowadays, there are special products. I don't know what to call them, but they are kind of looking like a nipple itself that you encourage the mother to apply on the nipple that helps the nipple. Actually, it helps to propel that nipple out. So I think we are more advanced in Kenya, and I don't know about other places, but one thing I know, Kenya tuko mbele. We have techniques, we have technologies that have come up to help these mothers with flat nipples. Thank you.
Thank you, Janet, for that. There's a comment here from Justus Ngula. When a mother is not able to produce milk, you can use formula until the mother is able to produce milk, then stop formula and continue with breast milk. That is not mixed feeding. Really? Thank you, Justus. But I think if we really support these mothers, they'll be in a position to get milk early enough. Yeah. There's a comment here. I saw my sister apply pepper. The boy stopped breastfeeding. That's so interesting. That's so interesting. Thank you for that. You apply pepper, they wipe, and they continue breastfeeding. There's a comment here. Can express breast milk be given to baby via feeder? I don't know what Peter meant.
I want to mean, I think Peter is a boy child, so he's, I think, thinking of that woman who maybe has had sleepless nights. This baby maybe has cried the whole night. So she can actually express that milk and give the partner or someone who is next to her to help her feed. I want to mean you meant that can breast milk be expressed and given through cup or through a bottle? So I will advocate for a cup because it's easy for one to wash and there are reduced chances of infection. But if it's washed well, then we can say a feeder is okay as long as we're giving the breast milk. Thank you, Peter.
Thank you for that. There's a comment here. What about applying Vaseline to cracked nipples? And in case of mastitis, should the mother be breastfeed while on antibiotics? So for this one, I think it will be important for this mother to take antibiotics. And of course, the other thing she needs to ensure is to express milk and discard, because you can't give the baby that milk. So it will be important for the mother to empty the breast and work on treating the mastitis before we continue breastfeeding. There's a comment there, CPD points, we will sort that. Thank you very much. Mokami Gitau, kindly talk about tandem feeding. Tandem. So even as we answer Mokami, there's a question here from Ratilal Samat Shah. If the mother has died, what should we do, or we start formula milk? I think for if a mother dies, if you're in a position to get the donor milk, the better. It will be better off. If not, then basically we may have to continue giving the formula milk. That one is really definite or clear.
I want to respond to Mukami Gitau's question about tandem feeding. I think she has brought this up because of a question that was asked earlier. If we can actually allocate one breast for a specific twin. And that is why she's brought up the tandem feeding, which talks about feeding the twins or the babies at the same time. So we see that breastfeeding can take time. So we need to be patient and let us encourage these mothers to breastfeed, whether it's a twin or triplet, we can actually do tandem feeding. By tandem feeding, we mean feeding the babies at the same time. Wakiamka wote, one holds the other breast and the other one holds the other breast. And that is why the football hold is very applicable on this area, because one is on the right and one is on the left side. They are feeding at the same time, and you do not have to allocate specific nipple for a specific baby. They can actually share because they came from the same place. Thank you.
Thank you, Janet, for that. There is a question from Emily Mwoki. In regards to donor milk, who are the major donors of that milk, and is it reliable to support a bigger population if need be? I think for this, what I can say is that for the donor milk, it all comes from mothers. It's just like a donation. This is basically donating. So it will come from willing mothers, mothers who are willing, who have extra or excess milk. They donate, the milk goes through a process and then screening and all that. And then from there, then it is safe for use. So I'm not so sure if it can really cover a bigger population, unless then probably many facilities put up machines and infrastructure to support the same, which is very important for our population. Thank you, Emily. And I think we are about to finish. This is actually our last comment from it's a question from James Kaibei. Thank you for the presentation. Please elaborate more on contraindication on breastfeeding in TB infection, considering the importance of breastfeeding for both mother and baby. Indeed, this has been a very, very insightful time. And actually, even as we come to the end of our session, I'll kindly request you can throw in where you come from, just to see where you are listening from, and just to appreciate the team and the participants. So for the question from James Kaibei, you were talking about contraindications of breastfeeding in TB infection, considering the importance of breastfeeding. I do agree that indeed we are emphasizing on the importance of breastfeeding, and the benefits are for both the mother and the baby. And indeed, once we are sure that the mom is not in the infectious stage, then it's very important to feed. But if the mother is in the infectious stage, then the mother may temporarily not breastfeed the baby, but instead she has to express the milk, and then it can be fed via cup. Yeah. Thank you very much, James, and thank you very much, participants, for being part of this great team. Indeed, it's been a great afternoon, and we really appreciate for the questions. We appreciate for creating time to be part of us, part of this team. So on behalf of KNH and UON, may I take this opportunity to really appreciate our presenter, Janet Wali. You've done an awesome work. Thank you very much. I know we will call you again soon to take us through something about the neonates again. I also take this opportunity to appreciate the facilitators and all participants, the nursing standards team, medical research team, and KNH and UON team. I really appreciate for being part of us. We really, really appreciate. At this time, I wish to welcome my colleague to just give us way forward on how we are going to get the CPD points. Have a nice afternoon and see you. Thank you very much.
Okay, thank you. Thank you, Joan and Janet. The presentation has been quite informative and elaborate. My name is Franklin Barine, CPD coordinator in nursing standards. I wish to inform all our participants that we will be sending out a CPD code. This presentation is CPD accredited The procedure to claim your CPD points will also be attached. Thank you very much for being with us. Have a good afternoon. Thank you.
Bye.
Bye-bye. See you then.